Hello and welcome to Child and Adolescent Psychopharmacology. I'm Dr. Audrey Robinson, your guide along this, and if you've been following along with my other lectures, look, I got a new headshot. Yay! Thanks to my friend Rachel who took a fabulous headshot. I teach counseling psychopharmacology at Texas A&M University Commerce, and you can email me with any questions. All right, so let's talk about the risks with medications and pregnancy. So we're kind of really weighing risk versus risk here when we look at psychopharmacological medications and use during pregnancy. Obviously, there's a reason that a pregnant woman would be taking these medications. So you weigh the risks of stopping a needed medication versus the risks of taking that medication during pregnancy. So in general, across all pregnancies, there's a 3% risk of congenital malformation. And so we're going to talk about the risks in different areas before pregnancy, during pregnancy, and after pregnancy. So effective June 30th, 2015, there was new legislation that began requiring updated labels on medication. Previously, there was like this 5-risk category, and it didn't include risks for after pregnancy, like with breastfeeding. However, this has been a slow rollout, and many medications that were made before 2001 still have the old labels. Okay, so talking about the types of risks, there's teratogenic, don't know if I'm saying that right, which is a birth defect, usually something structural. Then there's postnatal behavioral abnormalities, postnatal being after birth, and then perinatal syndromes right before or right after birth, or neonatal toxicity from breastfeeding. Keep those things in mind along this journey. All right, in general, a fetus will have about the same blood level of a drug as does the mother. So during this, we're looking at this cost-benefit analysis. We're also really not going to go into specifics of each substance of abuse because those are covered in other lectures. So we're going to look at medications, not substance use. All right, so let's focus on psychotropic drugs. The use of these during pregnancy and breastfeeding is controversial. So let's break them down into the different categories and let's look at antidepressants. So conflicting research on what happens. There's a small but significant increased risk of having a baby with major congenital anomalies or being stillborn in several of the SSRIs and non-SSRIs. There's also risk of Chiari type 1 malformation, which is where the cerebellum tissue extends into the spinal canal. And that is 18% with use and 3% with mothers who had no history of depression. So that is a pretty staggering amount there. There's no long-term neurodevelopmental impairment, but it's possible that there's increase in motor, speech, and language issues. There's no clear causal effect for autism and antidepressants. All right, let's talk about antipsychotics. Pregnant mothers with bipolar or schizophrenia who abruptly terminate treatment or abruptly stop taking their medication have a high risk of relapse. This is, again, where we're weighing that risk versus risk. What's the risk of the medications versus the risk of being unmedicated? There are risk factors for both. No teratogenic risk with atypical antipsychotics, but more risk for postnatal disorders. Many studies show no long-term or absolute increase in risk. So one study with antipsychotics found 3 times more likely to need more specialized nursery or NICU care, along with some premature births, respiratory distress, and withdrawal. Monotherapy has a small risk versus the polydrug for mother and child when we're looking at antipsychotics. There's more safety in just taking one versus multiple. There'd be that polydrug. All right, mood stabilizers. So let's look at mood stabilizers. Untreated bipolar equals a relapse to drug alcohol abuse, more manic episodes, interpersonal life disruptions, early postpartum, mania, depression, psychosis. There's a greater history for perinatal women of suicidal behavior, substance abuse, more difficulties during childbirth, and breastfeeding for those people who go off their mood stabilizers who have untreated bipolar. Lithium has the potential for fetal cardiac malformations, but lower levels are transferred by breastfeeding. So there's some data showing that it might not be good to take it during pregnancy, but lower levels of the drug are transferred on through breastfeeding, so it's a little bit safer. Again, this is all a physician's call. When looking at other medications, valproic acid, that VPA, has the highest risk of major congenital risks, such as lower IQ points at the age of 3 and an increased diagnosis of autism. All right, let's talk about what medication use in childhood and adolescence looks like. We have to balance the expected benefits of it versus the risk. So let's start off with SSRIs, and it's important to know that when we're talking about depression, there is a high prevalence of suicidal ideation and completed suicide among those untreated for depression and later development of more pervasive disorders, even personality disorders. So fluoxetine is approved for 6 and up. It's the best choice for when we're looking at that risk versus benefit, and even better when paired with 6 months of CBT. CBT is one of the easiest to research and assess, and so you'll see a lot of research over CBT. Doesn't necessarily mean it's better than other theoretical approaches. It just means it's more research. There's also a lot of research for play therapy. If you're interested in that, that's my wheelhouse. Duloxetine is available for 7 and up, and escitalopram, which is Lexapro, is for 12 and up. Children, when used in children, there's an increase in impulsivity during the first month, but it did not create suicidal ideation. That's really important. And that impulsivity was only during the first month. And that's when that medication is really getting into the system, and those levels are increasing and becoming therapeutic dosage. These are not to be used for PTSD, didn't work very well, but may work for OCD. Okay. When looking at suicide, because it was really important that once upon a time when we started using SSRIs, to treat depression, we came out with this warning label, and they put it on medication that said may increase suicidal ideation and suicidality. So then there was a reduction in prescribing and use of these medications, which then led to an increase in suicides. So initial studies showed that association of antidepressants with suicide, and then after that warning label and decrease in prescriptions, there was an increase in suicide attempts. So really what we're looking at is that there's risk with depression for suicide with or without medication. Okay, anxiolytics, anxiety rates are 10 to 20% and is often misdiagnosed as ADHD. We'll come and talk about ADHD in a later slide, or even as depression. SSRIs and CBT and continuation of that therapy for a year following the remission of symptoms is what worked best. And antipsychotics. All right, these are often used off-label for ADHD and disruptive behavior disorders. The side effects are the same in children as they are in adults. These can also be used for SSRI-resistant OCD. And it's important to note that when we're talking about these medications, oftentimes many of these are used in combinations. All right, so let's talk about those second-generation antipsychotics. When looking at schizophrenia, there's a slight overall positive effect for the use of these. With bipolar, there's slight improvement. With autism spectrum disorders, there's a decrease in irritability, decrease in lethargy and social withdrawal, decrease in stereotypy, decrease in inappropriate speech. So a lot of good improvements with autism spectrum disorders. When looking at these with use with ADHD, It may decrease behavior problems and aggression. That may word kind of gives you that like, but will it, won't it? I don't know. But then looking at some of these, lamotrigine is particularly effective. And when we're talking about like some of these antipsychotics and things, 1 in 3 develop schizophrenia-related symptoms of psychosis between 10 and 20 when we're looking at the onset of like schizophrenia. More boys than girls get prescribed antipsychotics until adolescent when it kind of evens out. And talking about like juvenile bipolar diagnosis, often mistaken for ADHD, conduct disorder, ODD, severe DMDD, temper dysregulation disorder. So juvenile bipolar disorder is one of those really controversial things that gets overdiagnosed because we call it bipolar, but really it's ADD or, ADHD, it's conduct disorder, it's ODD, it's some combination of those. And so there's lots of differing opinions out there. When we're looking at diagnosis of bipolar, it's been found that irritability in pre-K, showing irritability in pre-K has been linked with a true bipolar disorder diagnosis later in life. And we know that OCD may emerge as young as 2. All right, the last little category here, cognitive inhibitors and mood stabilizers. These are not indicated for children and adolescents. So these are things like our benzos, lithium, tricyclic antidepressants. Those things should not be used in children. All right, let's talk about ADHD. This is an area of specialty for me. So I particularly enjoy talking about this and have done a lot of research and learning and training around it. ADHD is another controversial diagnosis. It used to be called ADD, and you will hear people refer to it as ADD or even correct people saying like, no, I don't have ADHD, I have ADD. So the new language is AD/HD, attention deficit / hyperactivity disorder. So anybody who has this diagnosis has the diagnosis label of ADHD, but it has 3 different subtypes. Inattentive, which is that kind that people often say ADD instead of ADHD, hyperactive type, and then combined type, which has both of those. So no matter if it's the inattentive type, the hyperactive, or the combined, it's all considered ADHD. So there's set criteria for ADHD, which interestingly enough does not include emotional dysregulation, although that has been proposed as new criteria, has not been added in yet. But for now, aggression, emotional dysregulation is not part of the diagnosis. Working in a school setting, people often wanted to say that kids who became aggressive and emotionally dysregulated had ADHD, and that was one of my pet peeves because that is not part of the diagnostic criteria for ADHD, and I think that goes along with the misdiagnosis and mistreatment, which is also can lead to it looking like treatment and medication designed for ADHD doesn't really work well because those kids might meet a different diagnosis. For adults, they have to meet the criteria in 2 locations and have some symptoms prior to the age of 12. Really with kids too, we often look at diagnosing in 2 locations, so school and home or soccer and home. Many people won't diagnose in pre-K, although you can, and even medications, as we'll talk about on the next slide, can be used as young as pre-K. So the APA says that there is a rate of 5% in the general population, but really it's much more in many places. It often varies widely in states. Texas kind of falls in the middle of all the states with like an 11%, at least as of the last census data. And so we are looking at really a rate of more than double what APA says should be there. And it's interesting that teachers perceive ADHD in their classrooms at a rate double what is actually diagnosed. And so if you're looking at 5%, teachers are perceiving 10%. If it's a state with 10% diagnosed, teachers are perceiving it at 20%. And that's pretty incredible to me. Working in the school system for many years, let's see, it's about 15 right now, I have noticed that while ADHD is not one of the most severe problems, it is one of the most commonly referred, and that's backed up by the literature as well. A. Biden and Robinson, a different Robinson, not me. I wish it was me, because that's a pretty fantastic research study there. And so it is something most often referred to outside people or the school counselor is ADHD. What we know is that 30% of kids diagnosed, no longer meet criteria for a diagnosis later in life. Some of that is because they were misdiagnosed. That may be because ADHD symptoms often look like trauma. So if we are filling out an ADHD type screener on somebody and we're not asking background questions like, has this kid lived through any traumatic events? Have they witnessed or been a part of or anything like that? If we're not looking at patient history, client history, then we may be missing and misdiagnosing a kid as ADHD and using those medications or things like that when really they would meet another criteria for different diagnosis. Interesting enough, sad and interesting, there is a double risk for premature death from unnatural and accidental causes for those with an ADHD diagnosis versus not ADHD diagnosis. All right, let's look at ADHD medications. So, methylphenidate, which is known by its brand name Ritalin, has been around since 1955 and approved for kids in 1961. Stimulants like Ritalin and Adderall, which is an amphetamine, are still the first line of treatments. With these, it's often a trial and error process where parents and children try one and they try a dosage, they may try another dosage, they may have to raise it or lower it, they may even have to try multiple medications. And because of this trial and error process and side effects, many parents and adults who take ADHD medications often stop taking the medications and quit through that process because of the side effects. They get frustrated, they get tired out. And anecdotally, my husband is one of those. He tried a non-stimulant medication and didn't feel like himself, and that was it. He didn't want to try anything else. All right, so looking at methylphenidate, there are several dosages, and there's no like one dosage, like this is the best dosage for everybody. It depends on each individual's makeup. GeneSight is one of those places that they'll swab your cheek and send it away and kind of tell you which drugs work best for your individual genetic makeup, which might help with some of that fatigue through that trial and error process. It comes in pills, chewables, patch, liquid. The regular formulations are rapid onset, or there's extended release designated by ER or often CR for controlled release. And dexmethylphenidate it uses just the active D isomer of methylphenidate, and so it is double the potency. And that's that Focalin, and it also comes in an extended release. Now we've got amphetamines, which have been around since 1937, and Adderall is one of like the most researched drugs ever. And they surpass methylphenidate in their use, and it is used more in women than with men. Adderall has 75% of the D-amphetamine isomer and 25% of the L-amphetamine isomer, and that is interesting because some of these new formulations look at using different ratios. There's Evykio, which is a 50-50 between the D and L amphetamine, and that new medication is approved for 3 and up for ADHD and 12 and up for the treatment of narcolepsy and short-term obesity. You also have lisdexamphetamine, Vyvanse, which is a prodrug, which means it is only broken down by GI enzymes. In theory, this may reduce abuse by using it in other formats like injection. It can also be used to treat binge eating. All right, another new formulation could be Adzenys ER. It is an amphetamine with dissolves. It's kind of cool. So when looking at alternative treatments, alternative meaning non-stimulant treatments, 10 to 30% of people don't respond adequately to stimulants. And so we've got things like tamoxifen, which is Strattera, FDA approved, SNRI, which is effective long-term for continued use throughout life. It's available for 6 and up. It starts to take efficacy at 4 weeks. It is a slower acting. Stimulants take effect immediately, pretty much. whereas this takes up to 4 weeks to start seeing efficacy and then 12 weeks for full efficacy. Then you have things like clonidine and guanfacine, which are antihypertensive alpha-2 agonists, meaning they are blood pressure medications, and they are FDA approved, and honestly, they work better. They have been shown to work better in conjunction with the stimulant than they do as a monotherapy. There's lots of side effects that go into, that come along with these. Some of these are things like insomnia, elevated blood pressure. We're talking about stimulants, side effects with stimulants here. Elevated heart rate, reduced appetite, possible growth suppression, although some studies have shown that it initially has growth suppression, but everything kind of evens out eventually. It could also have new or worsening behavioral and thought problems, bipolar illness, aggressive hostility, psychiatric symptoms like hearing voices, believing untrue things, increased suspiciousness, increased manic symptoms. These medications are not for use with known heart issues. That lisdexamfetamine has also been known to improve emotional lability, like switching from one emotion to another quickly. It helps to improve that fast switching. Many stimulants also reduce the risk for new depression, suicidality, trauma, and injury. Stimulants do not increase the risk of tics. This is really important because there is a comorbidity between ADHD and tics. It is not increased by medication. All right, there was also some clinical trials that are of note. The PATS, which involves pre-K, looked at methylphenidate, and it had good improvement, but it needs to be noted that those pre-Kers who had moderate to severe ADHD symptoms did not show as much improvement, and it was considered chronic. Often they had comorbid conduct disorder or ODD diagnosis, and there was often use of antipsychotics along with the stimulants to treat those. MTA group is one that you need to know if you're going to do any work with ADHD. They looked at 4 different categories, and the 2 that worked best were intensive med management or medication and CBT. Now, CBT gets researched a lot because it is easy to quantify, much easier than many of the other like humanistic type theories. And so that doesn't mean that CBT is the only thing that works, it just means that it's more researched. And I'll talk a little bit more about play therapy and ADHD in just a second. That is a really well-researched one. When in that MTA study, 25 to 30% also had antisocial behavior and might have met criteria or had a diagnosis, comorbid, of conduct disorder or ODD. Long-term, there was still a difference between the ADHD and the non-ADHD groups, meaning whether or not they stuck to their medication and used it regularly, or they took holidays and used it irregularly, there really was no difference between those groups, and there was still a big difference between those who had an ADHD diagnosis and those who never met criteria. So that is not really encouraging for the use of medications stimulant medications over the long term. I did research on the efficacy of play therapy with first graders who were diagnosed with ADHD, and it was shown to be effective. I did 18 sessions, which was 3 sessions, an intensive 3 sessions a week over a period of 6 weeks. It was effective for improving time on task, decreasing oppositional behavior, and decreasing some other ADHD type symptoms. It is important to note ADHD medications do not address the underlying symptomology. They only modulate the expression of the affected behavior. ADHD medications work on what is expressed, not on the underlying symptoms. I think that's pretty profound. All right, I want to make sure I talk about what is real with ADHD and stimulant abuse, because there's a lot of misinformation out there. ADHD, the diagnosis itself, untreated, is associated with increased likelihood of substance abuse. Stimulant medication reduces, or at least does not increase, the probability of substance abuse. People out there like to say that if you take stimulant medications, you're going to end up with substance abuse, substance use. abusing stimulants, that is not necessarily the case. When studies have looked at the misuse of stimulant medications, it has been by college students, not for recreation, but for academic purposes. Consistent treatment of ADHD also means that a person is less likely to start smoking. So again, ADHD itself has an increased risk in stimulant abuse. That is not because of the medication. Medication has been shown to reduce or at least not increase the probability of substance abuse. All right, here are our references. Thanks to Slides Carnival for the pretty slideshow, and reach out to me via email if you have any questions. Thanks for watching.